So Spectrum Medical Partners, if you don't know about us, we're actually a platform company, and I actually don't hope that you sort of don't know. We actually focus on helping physicians when they grow their practice to a certain point and need assistance with either a revenue cycle or IT or some of those other things. Most times it's that they've grown to a place where that becomes overwhelming. We're like, you keep focusing on quality, reputation, your commitment to the representatives within that local community, and let us take it away. So depending on where you're at, you may know us from a multitude of different names, where we have hospitalists as well as SNFs, as well as specialties within SNF communities, as well as acute rehab. So we have the full, no pun intended, spectrum of care. We focus on extraordinary results. That's an item for us. So again, depending on where you're at in the state, you'll know us under different names. Okay, to your left is Dr. Vallejo, and he leads a dedicated SNF physician serving Lake County as well as the Orlando market, with over 8 years of exclusive experience in post-acute.
Dr. Britton has built a distinguished career as a hospitalist and a skilled nursing physician, bringing a unique blend of expertise in both acute and post-acute care. He graduated from Wayne State University with specialized training in translational hypertension research, internal medicine, clinical internships. Dr. Raj is a 22-year veteran hospitalist. He graduated med school from Armed Forces Medical College in India in 1996 and completed his medicine residency in the University of Missouri, Columbia in 2003. He founded a hospitalist and SNF group in South Florida and is the medical director of 2 skilled nursing facilities, and brings a dual perspective of acute and post-acute medicine and transitions to our panel discussion.
She's also known for meaningful innovation, problem solving, and big data and emergent technology. So her experience and unique skill set have afforded her the opportunity to be featured by media outlets, including Bloomberg TV, Forbes, and she's spoke at several national conferences. Talk about some innovative, like I talked about earlier, community-based strategies and partnerships that have really begun to show some promise in the industry.
How do hospitalists and SNFs align around shared accountability and proactive intervention? And Ashley, I would like to go ahead and give you that first question.
Thanks, Ruben. We're seeing such a high return rate despite all of the initiatives we had in place. I had team members that would even follow the patients into the facility. We had programs where they would alert us if they're coming back to the ER. We had certain facilities that were willing to partner and make sure we could just send them back to the ER for procedure and then turn right back around and get them back into the facility versus admission for that procedure. So multiple things, but we couldn't quite figure out what was in this, why was the rate still high. So it was a real opportunity and eye-opener for me, for someone who had actually been familiar with Spectrum from my past at another organization, but not knowing the full breadth of their capabilities within the facility space. It started having conversations with Dr. Vallejo, who I kept hearing this name, didn't know who this person was, but I kept hearing I had to talk to Dr. Vallejo as the medical director for some of our local facilities.
We do have a clinical team starting from attending physicians and nurse practitioners that rounds them in the facilities. We found it's very important to have the input of the medical director when it comes to maternal hospitals. A lot of treating patients in-house has to do with how comfortable the clinical team feels about treating those patients in-house. Has to be a lot with how well they know the team they have, the nurses, the CNAs, the DONs, how well they know the capabilities, because sometimes it's not even just the hospital doesn't know the capabilities. Sometimes the delivery mat is not even the clinical team rounding that the facility knows what we can do for those patients in-house before sending the patient out. So adding the extra layer of having the medical director directly involved with any potential transfer to the hospital to make sure that everything that we can do for that patient has been done safely adds a lot of value in try to keeping those patients home back from a return to hospital.
They discuss it as a team, and you know what the families need. That even that one patient that was living alone. It's not going to be, you're not planning, especially if a patient has some type of fracture, sending that patient alone back home. Because what is going to happen is that that patient cannot function at home, and it's going to require to be readmitted. So these are the things that we have to set up and integrate within our course of each patient, so that we can really make an emphasis and making sure that patient is not going to be going back to the hospital anytime soon.
We identified as palliative patients. However, it took 3 attempts or 4 attempts for them to go from the hospital setting to the skilled nursing facility, back to the ER, back and forth and back and forth. And after the 4th attempt, we said, oh, you should probably be palliative, and maybe we should bring SPIS into this equation, and maybe you're not, this is not a word in English, you're not rehabable. So we figured it out. So one of the things that we did was to say, let's pre-screen these patients, make sure that we created a program called QLife, which is quality of life. So we had to screen them and say, can you actually do something for these patients before you push the button in CADboard to ask for a rehab consult? Because what we saw was that we used to get your length of stay is about half a day more than it should be. So we were pushing the button to say, send them to a SNF because there is no place to send them. Obviously, they went to the wrong place because it was right place, right care at the right time. That was what's the word for it? And that was the motto for the hospital system, but we were choosing the wrong patient to the wrong place at the wrong time. So we were doing everything opposite. So once we started screening these patients for palliative, then we realized that if you don't push the button in the front end, people are not accepting the patient on the back end. And if they're not going to the skilled nursing facility, they are not coming back to the emergency department. So it was a simple little understanding as to the population which was going back and forth.
You're beginning to touch on at the very end is hospital length of stay. That's a strong metric, and it's a very strong financial metric. So I get it. I know that's why it's important. But I would guess that in your analysis, you would have seen maybe a drop in length of stay at the hospital, but a corresponding increase in return to hospital. And I'm assuming they want both. CMS wants both, right? They want shorter hospital stays and less return to hospitals, but they go against each other to some degree. So that's the challenge. But is that what you're seeing? I mean, I don't know. Are you seeing shorter length of stays?
So I actually did a cross analysis of length of stay compared to the return, and it wasn't actually much of a correlation. So it wasn't that we found, it was actually the time that they're spent. They had a longer length of stay because they were waiting for a bed. So we couldn't get them to the facility. But our discharge home actually was the lowest readmission rate across. It was certainly SNP and home health that had the highest readmission rate. And it was because we were waiting to get them placed from the SNP side. And then that correlation on the home health side showed that home health wasn't showing up within that 24 hours, and we didn't know it. So we only knew because I had my team calling the patient. The patient would say, I haven't seen anybody yet, and it's been 3 days, kind of thing. So that's what we found in terms of that higher retention rate.
I also would say that we also have initiated what we call a safe transitions home program, and you do that on any patient that we have, whether they're hospital, post-acute rehab, or skilled facility. We have seen some major differences in that, and I hope that you gain something from this. We'll be here throughout. We're glad to answer any questions, but like I say, I feel like that we've had a little bit of a unique situation where we get to hear these guys banter back and forth quite a bit. They each have their own take on things, but as a practice, we've learned how to take some of each of those and how do we really push that forward. It's also, I hope you've heard throughout today that in spite of what we're doing, we also will tell you stuff that we see that's successful and that's going to help us or just help you in general. We're always open to that. I think if all of us get to this core place of what can we do to really improve overall outcomes and the quality of the patients that we take care of, it's the right thing, whether it benefits us directly or it just benefits the industry as a whole. So that's who we try to be, sort of what the mottos we go by. Again, thank you for joining us. We hope you got something out of it, and